one of our newest partners at the University of Colorado in CU Sports Medicine, Jamie Gennaro. He is with Stedman Hawkins, and they just joined us this past year. And he's a sports medicine doc, been doing a lot of neat things with the hip, and previously was one of the team docs with the Broncos and helps out with the Rockies. And Jamie, happy to have you.
Thanks, EMAC, for inviting me. I appreciate it, the opportunity. And Rob, great talk, and Omer and staff, great talk, so thank you. Always learned a ton. I'm going to be talking about FAI return to play. This is a typical patient that comes into clinic, and I think it brings up a lot of questions. It's a 23-year-old left-hand dominant pitcher. He's had left groin pain for the last 6 months. He has symptoms of squats in training, pitching and hitting, but he's been able to continue to play despite the pain. His physical examination is typical, what Steph just went over with an FAI with positive impingement signs, scour maneuver, limited internal rotation. His x-ray, which Dr. Major went over, large cam bumps on both sides, no significant dysplasia. His MRI also has a labral tear. So this brings up a lot of the questions. What do you tell the player? Do you treat it operatively, non-operatively? What about injections? What are the results of surgery if we do? On time to return to play? Will he return to the same level of play? And what is the risk if you delay treatment? Timing of surgery, he's in season. Do you wait till the end of the season? Do you try and get him through another season? So I wanted to go over this. This is a Min Coker paper where I did some of my training at the Boston Children's Hospital on non-operative management of labral tears. He looked at 76 adolescent athletes between the ages of 14 and 18 with FAI. I think the important point on this slide is the majority of them ended up with surgery. So only 23%, whether they had a labral tear or no labral tear, did well non-operatively with physical therapy and injections in the long run. And that ultimately, even these are young patients, 3/4 of them ended up with surgery despite 6 months of non-operative treatment. Anecdotally, we followed our patients for 2 years and found between 15 and 20% of our patients presenting with FAI had long-standing improvement with non-operative treatment. So I think it's important to tell this athlete, we certainly can treat you non-operatively, but there's a good chance you're still going to have symptoms at the end of the day with playing. This is just a symposium that Ben Dome put together looking at intra-articular cortisone, or HA, injections in the hip. And currently, when they reviewed all the evidence, there's limited evidence to warrant routine use of intra-articular injections for long-term management. Steph alluded to it a little bit. In-season athletes, I think it's reasonable to consider cortisone, but wouldn't expect long-term benefit or efficacy from it. So that brings us up with surgery. Looking at the return to play, this is a study by Struan Coleman and his colleagues out at HSS. Return to play rates in competitive baseball players. These were minor and major league baseball players that they looked at, was just published last year. Bottom line, the return to sport rate was high. It was 88% at a mean of about 8.5 months, with 97% of those returned at the same level or higher levels. When you look at this compared to a lot of the other surgeries we do in sports medicine, like ACLs, which is commonly accepted, this is much higher than ACL return to play rates, UCL, all these things that we don't hesitate to tell these players, hey, you need to get this done. These are something that, this is still a difficult discussion with the player. What about sports other than baseball? This is a systematic review. They looked at 18 studies, had a very similar rate amongst all the different athletic competitions, where 87% of the athletes with symptomatic FAI returned to sport after hip surgery, and 82% of those patients returned at the same level of sport. So I think it's important that the results across the board with FAI surgery are very good, if not better, than a lot of the other accepted things within sports medicine. Their summary is there's high return to rates of sport after FAI surgery. It's not generalizable to all hip surgeons and facilities. If you have osteoarthritis, you probably want to talk about something other than FAI surgery. Return to sport should not be used as a single outcome. and perhaps there would be more sensitive metrics to understand how patients do with hip afterwards. This is a study that just came out 2 months ago in AJSM by Mark's group up in Vail, where they looked at return to play in professional football players. Again, they found 87%, so what we're seeing is high 80s in getting back after FAI surgery. And when they returned to play, their total length of career was actually long. And 92% of the players who returned had a minimum total career length of 3 years, which is longer than the NFL average. So they did well, and they did well in the long term getting back to sport. Timing of surgery, because a lot of your athletes will say, well, it's the beginning of the season, I'm just going to wait and get it done next year because I know it's a long recovery. I know it's going to miss this whole season. And so the question becomes, is there any risk in delaying these patients and trying to get them through the year? So this is timing on hip arthroscopy. Does it really change clinical results by Ricky Villar's group now a couple years ago. At the timing of surgery, they divided them into 3 different groups, A, B, and C, based on under 6 months, 6 months to 3 years, and over 3 years. And the conclusion is they recommended patients with FAI should undergo hip surgery within 6 months of symptoms because that group A did the best. When you look at revision surgery rates, the revision surgery rates in that group that got treated early was significantly lower than groups that got treated later. And even above 3 years, that revision rate was almost 15%, so it was quite high if you delayed things. This also is just kind of follow-up with Mark's group again on predictors of career length after hip arthroscopy in professional hockey players. They got back at a high level, but when you divided them subset based on how long they had symptoms, you found out that the patients who were younger, which probably is a surrogate for less osteoarthritis, and had shorter duration of symptoms prior to their surgery, had a greater length of career in years played after hip arthroscopy. So again, if you treat them early, they tend to have a better outcome with a higher return to play rate and a longer career length. So this is just my algorithm to kind of summarize it. Players with symptomatic FAI with x-rays, MRI, and an exam all consistent with but minimal chondral changes in an in-season athlete. If you're able to return to play, I'll talk to them about continuing to play. Avoidance of hip flexion activities. I think this is really important, and Rob, you probably have seen this quite a bit with FAI, that there's a tendency in the gym with the trainers to get them on low squats, and going low below 90 degrees with weighted is tough on the hips. Even something as simple as airplane seats in the bigger players. We've had one of our Broncos that we just moved him up to first class, and he seemed to do a whole lot better. I don't know, you read into that whatever you want. But he did on the away trips, the big away trips, anytime he was sitting in a cramped back area with his hip inflection, his hip really was sore the next day. So avoidance of those hip flexion activities, possible corticosteroid injections. I'll consider one during a season. I typically don't do multiple during seasons, may consider HA to get through a season. If you're unable to play or your level of play is affected by the hip FAI, I would consider surgery. If you're out of season, I would consider early surgery because there's a very high level of return to play within 6 to 12 months afterwards. So the conclusion on all this is FAI treatment in athletes can vary based on your symptoms, duration, and severity. Non-operative treatment has a pretty low long-term success. It may allow a patient to get through a season, but likely if they want to continue to play, they may do better with surgery. Operative treatment has high return to play rates, really above all the other conditions we see within orthopedics. And the longer the delay in surgery typically portends a higher revision rates and potential lower return to play rates and a shorter career length. So thank you very much.
All right, can I get this the second mic on, please? And then can I have all the hip docs that just talked and PT come on up? We're gonna just have a chance to take some questions from the audience, and I know about FAI because I was diagnosed. It wasn't called FAI back in 1991, but I was a medical student and I was starting to have hip pain doing 10Ks, and they said, "What's wrong with your hip?" They looked at it and they said, "Well, you must have had some kind of birth defect or something," but it was actually FAI, and I know that now. So I quit running, and I've been able to live with FAI non-operatively for the past 25-something years and just ride my bike. But very interesting. So come on over here, guys. Hey, questions for these guys. That was a great session. Yes, right here.
In our practice, we're seeing more for like police and fire, military, people that are in their 40s, and they're having a harder time finding that time frame to get their surgery done where it meets their needs for family. Do they still have the same outcomes at that age if they get their surgery done within that 6-month period you're talking about, or do they have a longer period of time to recover?
Omer, you want to answer that? You want to, okay.
Sure. Yeah, I think Jamie can talk about some too. I mean, I think that a lot of people that I think the bottom line is it depends on how much arthritis they have at that point. That's really been one of the biggest predictors, I think, of FAI surgery once we get into that kind of, especially 40, 50-year-old population that we're trying to figure out, is it okay to do an arthroscopy or not, or is it at least it's okay? Is it going to give them long-term results? Is it worth doing? And I think that's really the biggest predictor. So a labral tear is probably not going to have as much long-term healing potential in someone who's 16 versus someone who's 40, who's, if they have their tear because they have FAI, it's been beat up their whole life. They're just finally having symptoms from it, and so their tissue quality is not quite as good. But I think really the biggest predictor is how much arthritis they have, and so there's not really a good blanket answer for that. I would say if you wanted to say, do they have as good of results as a 16-year-old? Probably universally no, but that doesn't mean that they can't have the surgery and get some relief from it. But it's really individual a conversation with the patients based on their particular pathology.
Yeah, just to follow up on that, I think arthritis, like Steph mentioned, is probably the biggest predictor. But in the absence of arthritis, Tom Bird just presented at ANA this spring his results on patients over 60. So not even in the 40-year-old patient, but in the absence of arthritis at 60, patients still did just as well as the cohort in their 30s. So I think there absolutely is a role. I'm working with Chad Mather at Duke on a decision model because there's a lot of patients that come to our clinics who are in their mid-40s who have no arthritis, but they're told they're too old for FAI surgery, which, again, I would say in the absence of arthritis, it's something where I think patients can do just as well. It's something where you do have to counsel them because those athletes are very similar to firefighters, that it's going to be 6, even 12 months until they get back to full level of their profession. So just as long as they know how long it is. The hard part is they can probably get back sooner with a hip replacement, but at 45, do you want a hip replacement when you know that it's going to wear out? So this is a tough group of patients for us.
Just to re-emphasize that, as discussed, we need to look at the biological age of the joint, not the chronological age of the patient. We can see patients which are 60 years old and we cherry pick them for this surgery and the joint looks like a 30, 35 years old joint. And we sometimes see a retired NFL player at the age of 30 and the joint look like 80. And we're not going to operate on him because we know it's going to fail. The joint space is about 1.5 millimeters. So the biological age of the joint is the most important parameter. Then there's the age of the gender. We know that males do better than females over the age of 40 in general, globally. And it would take longer for a patient over the age of 40 or 45 to heal, but they usually heal and result in a very good outcome.
You got anything to add, Rob?
Just be careful with these things because oftentimes people say, well, we have to get everything going, so we'll get your quads going, et cetera. If you light up those hip flexors, it's corresponding to me like having a biceps tendonitis. It's a bear to deal with and it's a bear to get rid of. So just be careful you don't light up hip flexors as you start going through your rehab process, especially in early phases.
Another question. Do you have the mic right back here?
I got a two-part question for Rob. On your elite sprinters, I'm interested where on foot strike are they hitting their foot? And that's the second part is you take a runner that comes into your clinic. If you change their running engram and improve their strength, their core strength, how much percentage increase in their speed do you see before and after?
Okay, one is I don't treat elite sprinters. Like, I don't train world-class sprinters. I work with football players, basketball players, et cetera.
Any athlete.
Yeah,
is
so
fine.
what we do is essentially take the principles of strength and conditioning and just apply them in either setting. What we do, and this may not please everyone in what I'm about to say, is that we don't do anything sports-specific. Not in rehab, not in training. We enhance athleticism. So we get them stronger, more powerful, more elastic, faster. The participation of practice and playing the game is what's sports specific. So I'll give you an example. If you worked with someone, got them stronger, a little bit more powerful, and you increase their vertical jump, as a basketball player, they may have avoided an outstretched hand to block their shot, but we did nothing for their shooting percentage. They enhanced their shooting percentage by practicing shooting. And so that's why I say, in the clinical setting and in training, we enhance athleticism. So go back to your question, by enhancing the athleticism of the athletes, we hopefully this carryover by getting technically proficient in sprinting, that they become better sprinters. And foot placement in regards to sprinting, I don't do distance running, but for sprinting, the foot should probably strike anywhere from 6 to 10 inches, depending on height, femur length, et cetera, anterior to the midline of the body. Once it starts going further, you're going to set yourself up for injury. Once it's shorter, you're not even going to have any force production.
There's a question up front.
Thank you. Yes, I would like to ask about indication of using intra-articular corticosteroid injection and hyaluronic acid in case of labial tear. I would like to know that what is the good time to injection, and how many cc, how many percent that you use for in the case of labial tear? Thank you.
That's a good question. All right, we'll start with Steph, and unless I don't think you're doing injections, so go through the three of these.
Yeah, I think, like I mentioned, I will use an injection sometimes diagnostically, and knowing that it may or may not end up being diagnostic. I really only like to do a steroid injection once or maybe twice. There is definitely some literature, at least in animal literature, that it may affect the chondrocytes and cartilage degeneration, and so we don't know exactly about that. But so I'll usually do it once or twice. Sometimes if it's diagnostic, it's it can be at any time point, just in the early parts of my diagnosis with them and trying to get them maybe more active in physical therapy. Sometimes, like I said, I'll use it to get someone through a season if we're planning on doing something at the end. So I think it's kind of varied based on the patient, but it's not something that I think a lot of patients have the perception that they have a lot of parents or friends or something that get injections all the time, and it's usually in that indication it's more for arthritis where kind of the joint is already in that state and we're not as worried about it, and just kind of getting someone by until a hip replacement or something like that. So it's important to counsel them that this isn't quite the same situation for that. So I think it's a little bit individualized. In general, I think there's a combination of some sort of an intra-articular anesthetic that is used. And that can also be more of the diagnostic information more than their response to the steroid, because I think that's really variable, as I'm sure you've seen in the knee and the shoulder. But really the response and how they feel in that first 30 minutes or hour when they provoke the joint, when it's in the anesthetic phase, is more important diagnostically. So that's kind of my algorithm.
Yeah, just to follow up on that, I think there's 3 indications for me for hip injections. Number 1 is diagnostically, and typically I'll use just local anesthetic if you're doing it purely from a diagnostic standpoint. I think Jason Dragoo's work would say bupivacaine may be the least toxic on the joint. So if you're going from a diagnostic standpoint, I typically would just do 3 to 5 cc's of the bupivacaine and then re-examine them. And I think the examination, give them a few minutes to set up, I think is probably the most important, that exam right after. The second group is the in-season athlete, like we just talked about. To get through, on average, when you look at the literature, it's about 2 to 3 months of relief with a corticosteroid injection. I'll do 1, but I won't do a second in-season. I'll try HA as a surrogate for that afterwards, because I think it's probably a little less toxic on the joint. As we mentioned, I think The integrity of the cartilage is the most important predictor of your long-term outcome with hip arthroscopy, so you don't want to do anything to damage that. The second part of that with the cortisone is typically I will delay surgery after a cortisone for 6 to 8 weeks. I think the total hip literature is coming out that you may even want to delay it up to 3 months after cortisone because risk of infection and decreased ability to heal. So you're always cognizant on that, on timing with the cortisone. And then the third group of patients is the group that Steph just alluded to. These are the patients that are your 45-year-old patients that are down more of the arthritic pathway. And in that group, I think you have a whole host of options for injectables, whether that's cortisone, whether that's the HA derivatives or the biologics. I know Omer's doing a study on HA and PRP, and he can talk about his results. We're doing a clinical trial on HA. I think it's at least as effective as it is in the knee.
I agree with all that being said. I think that we have a very good way and ability, well established to diagnose intra-articular pathology with a good physical exam. So I would use injections, and I'm trying not to use steroid if I don't have to, only when I want to try and differentiate between different sources of pain. I'm not convinced the physical exam gave me the hip joint as a source of the pain. So if I'm not sure if it's piriformis, hip joint, maybe hamstrings, maybe something else, maybe coming from the spine, I would inject usually lidocaine only and try to differentiate, and meaning excluding the hip joint is the potential source of pain, see if that injection took the pain away or not. I would usually try not to utilize steroids as a source of treatment, as a method to treat the joint. We know that efficacy would go away within a few months, so I don't think it's worthwhile, definitely in light of what it can potentially do to the cartilage. But again, with in-season athletes or with young athletes, we want to let them finish their growth or whatnot. That's definitely a valid option. In terms of biologics, I prefer PRP over HA, even though I think that both would give good results in the short term. Sometimes PRP can last, definitely with the older folks, up to 2 or 3 years. And that would be, I think, even a good in-season option. The thing is that unlike steroid, it's not a magic wand. It will not work immediately within 3 to 4 days. It usually takes about 4 to 6 weeks for the PRP to take effect. So if we need the patient to be able, the athlete to be able to perform immediately, then steroid would be a better option.
Any other questions? Omer, how quick is your case? Do one case. So Omer's going to run through a case real quick with us. Thank you, guys.
Okay, so this is a case of a 28 years old patient, with right hip pain 2 years after a fall. The patient is an aerialist, and she failed conservative measures. On physical exam, she had both provocative tests, the flexion, adduction, internal rotation, and the Faber positive. The lateral center edge angle is 23, so kind of on the upper borderline dysplasia range. Tonus 11, again, kind of a little bit more than the norm. So again, borderline dysplastic, and the patient is Baton 7, so meaning significant hyperlaxity. When we look at her soleus, as we talked before, we can see that soleus is a little bit upsloping. So again, another potential instability sign. But when we look at the CAT scan, so the torsion is normal, 14 is dead center, and the version is normal, between 15 and 20 is normal. She definitely has a significant cam lesion we can see on the 3D images. But the main issue here, as we can see both on the MRI and the CAT scan, as you can see over here, is significant subchondral cyst. So this is definitely a significant joint damage on a patient which is very, very young. So at that stage, Jamie, would you just proceed with hip arthroscopy? Steph? Okay, so Jamie brought up two very important things. First, if we have imaging modalities that can actually show us show us what's the viability of the joint, of the cartilage, and if we move ahead with it. There was a group from Boston, very famous group, that came up with the degeneric study, which is a study that supposedly shows us what's the quality of the cartilage in the joint by quantifying the glucosaminoGlycans portions in it. I have to admit that, at least in my hands, even so I do degeneric, or at least I did degeneric quite often up until recently, up until Nancy Major indicated that maybe it's not that good for the patient because of the excessive radiation and additional radiation associated with it. I didn't see significant correlation between the degeneric value and what I saw in the joint, because many times the cartilage would pick up, the glucosaminoGlycan would pick up the gadolinium, and the number would be relatively high, but at the end of the day, when you get inside, it's all a cartilage flap. So the flap picked it up, but as you take the flap out, now you're with cartilage damage, which is grade 4. But I agree, we have to think about something else, because obviously hip arthroscopy alone would not be a good solution for that patient. So in that patient, as you get into the joint, you see the significant cartilage flap. And that flap obviously has to go before, because we have to, very similar to the concept that we utilize in the knee and the shoulder, we have to break or interrupt the subchondral bone so the bone can heal. But as we understand, there was significant Swiss cheese appearance of subchondral cysts. And these cysts usually have significant liner within them. So these cysts would not usually heal. As Jeremy said, we have to somehow take care of that in terms of realignment, because she's probably suffering not only from impingement, but also from instability. And we have to penetrate these cysts and try to take all these liner out, because otherwise these cysts would not heal. We have soft tissue sitting within the bone, and that soft tissue would not let the bone heal through, even if we realign that patient. And it's not uncommon for us to see a combination of both impingement and dysplasia. About 75% of the patients who have dysplasia also have cam lesions. And we have to understand these cam lesions not always take part in the impingement when the patient is dysplastic, because the socket is so shallow. But many times when we reverse that, when we give them more coverage, all of a sudden the cam is way more disruptive to the socket, because now the range of motion is reduced. So you can see that patients, we took the liner from the inside, and then at the end what we do is that we take bone graft. We usually use the inside of a shaver, and we run this bone patty inside, and we basically just fill the cyst with bone graft. And that's corresponds with what Dr. Gennaro said with regard to allograft. We can do it sometimes with allograft, but I prefer, if I can, to do it arthroscopically and just fill these cysts with bone patty, and usually then the stem cells would come out, would generate a nice layer of fibrocartilage there. You can see how it looks in the end. So now we tackle this bone graft, and the blood clot would even up on top of it. And then obviously take care of the cam lesion. And that's how it looks 6 months later. So you can see these significant subchondral cysts that occupy a significant portion of the socket, but 6 months later, after the bone grafting, there is no any remnants from that. So complete healing, because we restore that. And I would try and do that prior to committing for a PAO, because if I would not be able to fix the joint, then there's no point in proceeding onwards with the PAO. And then 6 months later, we can go ahead and do the PAO and reverse that under coverage, giving the patient a normal socket and a normal back to life. That's it. Thank you.
Hey, just a reminder, June 1st and 2nd of 2018, Omer is hosting the International Extreme Sports Medicine Congress at the St. Julian. It's really a fascinating congress of international speakers that talk about all the sports we love in Colorado and more. And so don't forget, it's in your packet. Registration is up sometime soon, right?